We could do a whole day just with our neurology team. And this neurology team, they are our key opinion leaders on our natural history study. So we do have the opportunity to meet with them often, and they are playing such a key role in driving our research forward through truly understanding our patients. So introducing Tim Benke, who's with the Children's Hospital of Colorado. Thank you for being here.
Thanks very much for having me. It's been a great few days, and thanks to everybody. So what I'm going to talk to you about today are top concerns, communication, sleep, and some general approaches. There we go. Those are my disclosures. So the top topics today. So I'm going to talk to you about the top concerns from the NIH-sponsored natural history study of retina-related disorders, which Eric spoke to you a bit about briefly, but I want to tell you a little bit more about that so we can compare and contrast what's been done with the citizen-based natural history study. I'm going to talk about sleep issues and approaches, and it's really important that this is the world according to Tim. And there's not a lot of data that's where we need a lot more data to understand that better. And the same goes for communication. And then just provide some general suggestions. So the NIH-funded natural history study of retina-related disorders has followed over 1,000 patients over 15 years. And as you might know, when it initially started, it also included Angelman and Prader-Willi syndromes. But then it shifted in 2015 to be Rett, FOXG1, and CDKL5. And this was Alan Percy at UAB. He was the principal investigator, along with Jeff Newell for this. And we completed as our funding finished in summer of 2020. And we used some revamped data instruments, but there were also some sub-studies. So the main protocol was this visit where we got a lot of parent data. There was a parental interview and a clinical exam. And then there was this other sub-study where we did the EEGs that Eric was just talking about. And these were the participating institutions and investigators, and there were several sites across the country, as you can see them listed here, from CHOP to Colorado, Boston, Vandy, Rochester, Greenwood, Baylor, Rush, UCSF, and so it was a group across the country. And that's kind of important to some of the next points. But it was funded by the NIH. It was your tax dollars at work. So the inclusion criteria to be in the study was families and caregivers, you had to be agreeable to consent, and it was females and males of all ages, and you had to have had testing done for MECP2, CDKL5, or FOXG1 genetic changes, and meet the requirements that there was an actual spelling change or meet the consensus criteria for typical or atypical Rett syndrome. And so the enrollment over 5 years was 1,000 subjects. This was our goal. But the main thing to look at is our goal was for 50 individuals with FOXG1. We actually had 59, which was really good. And what we did is we followed, if you were under 10, we followed you annually. 10 to 20, it was every 2 years. And if you're over 20, it was every 4 years, twice during the funding cycle. But there were some limitations to this. You had to be close to one of the centers of excellence or willing to travel to be part of the study. And one of the important things about that as well is not only were you willing to travel, is you had 2 to 3 hours to spend with your favorite people. While we asked you the same sort of questions, and you get asked the same questions again the next time, it was a definable condition called form fatigue that you were put through. But not everybody could do this, and the other issue is it also had to do with if your child was really ill, then you weren't going to be able to make it to these sorts of visits. So there were some issues with the data collection. I think we were missing on families that couldn't travel, and also missing on families that could have been more severely affected. So one of the things that we did for the study, and this is all courtesy of Jeff Newell, this was his baby, is parents and caregivers were asked to pick from a list of top concerns and list in order only their top 3. And there was also a free text option. And what this represents is it represents a relative concern and not a prevalence of a symptom. And the concern is dependent upon you recognize the symptom, and it's severe such that you put it into that, and also the duration. And if I were to ask you what your top 3 are today versus 5 years ago or 5 years in the future, your child may be having the same things going on. But you, as Eric said, you might get to be an old hand at fill in the blank, and it's not such of a top concern to you at that point in time. So these things vary. It's a snapshot. And this was all what we got from families, their top concern during the first visit. And so this was then analyzed by the top concern was weighted to 1, the second was 0.5, the third was by 0.3, and then the average weight was computed. And so these are the top concerns. And so the top concern was communication, followed by sleep, feeding, balance, constipation, abnormal movements, hand use, reflex, and vision. So just take that in for a second, and there's going to be a big caveat here in a second. And this is the rest. And you're going to look at those and you're going to go, but my top concern is really bruxism. Why was that not in the top list? And it really has to do with how the data was collected. It could have been your top concern, but overall, it was not the top concern when we did the analysis this way. So it's important to look at what was the first concern for people, because I think you learn a lot from the data. And so the first concern for people was 20% said seizures, and then 17% said communication. Now, because the sample was of a certain size, is seizures really different from communication? I think they're really battling it out there at top one. But then there's a clear separation. Then the next one is walking and balance. Oops. The next one is walking and balance. And then if you look at abnormal movements, chewing, and sleep, these were all rated by 6% as the next thing in the first concern. Then vision, reflex, constipation, weight gain, other GI was at 3%. So these are all somebody's top concern, but it was a smaller percentage of the total group. And then this is the next list, which is a much longer list. So 2% were still reporting all of these things as their top concern. So it doesn't, just because your top concern wasn't in that list with the weighting, it doesn't mean that somebody else didn't think it was a top concern. So why is this important? It all comes back to the FDA, because clinical trials must focus on outcomes that are meaningful to feeling and functioning, and that's their words that they like to use, in affected peoples and families. And the outcomes are, well, which symptoms are important, what changes in these symptoms are meaningful, and can these changes be measured in a clinical trial? So we can statistically say, oh, we got a change in a clinical trial, but was that little increment enough to be meaningful to you is an important distinction. And then the next big thing is can I measure that in a clinical trial? And successful trials need meaningful outcomes that can be measured. So we could talk a lot more about what that particular measure might be, but this is the first principle, what is important to families. And so I think that with what Ellie's done and what we have here, we're on our way. So I don't want to spend too much time on this, because I think we want to hear from Nadia, but one example that we have is our Rett clinic, and it's everybody with MECP2, FOXG1, and CDKL5 changes. We have a big group of people. It works for our part of the country because people feed the cows at 2 o'clock in the morning, and then they jump in their car and come see us, and so it's useful for them to get all of their visits done in one day. That sort of fire hose is not necessarily useful for everybody. And we've got a nice space in the hospital to do it. We get support from Rocky Mountain Red Association and from the International Foundation for CDKL5 Research. But what's key to our clinic is we have a nurse coordinator. How do we raise money? It's Colorado. We do fly fishing tournaments. So when you're done raising your $100,000 for FOXG1, come fish with us. So in our children's clinic, so I've got 10 families from Colorado and the surrounding states. Their ages 3 to 20. 10 families does not make me an expert, okay? But this is what I've seen. So the common features for everybody is epilepsy, communication, sleep, mobility, cortical visual impairment, the abnormal movements, and the GI issues. And so the things that I've been asked to talk to you about are sleep. And so the big question is, well, how do I know that sleep's really a problem for you? Well, one of the things is, and there's a typo here, is the sleep scale. So you guys have been filling out the Childhood Sleep Behavior Questionnaire, not CSBS, CSBQ. There's another scale called the Bruni. I've been doing the CSBQs in the Rett Clinic for a long time, but I found that they don't necessarily tell me what's going on because I probably am not using them correctly to add up to get a score. But this is my money question. It's how many nights per week do you have to resettle your child at bedtime? If you're saying more than one or more, then it's too much. And so the additional questions are, is it getting to sleep? And these are the questions that I have to ask you or your clinician needs to ask you. Is it getting to sleep, staying asleep, or both? So getting to sleep is initiation, staying asleep is maintenance, and it can be both. And the other big question is do they snore and do they nap during the day? And these are clues that if there's other reasons as to why you're not sleeping well at night that need to be investigated further. But then also, what keeps them from sleeping? You go through the list. Is there something going on with the GI system is primarily one of the issues. Is it seizures, et cetera? But then it's also a lot about the environment. What kind of bed do they have? Is it, just, are they still in the crib? Or do you have a special bed for them? And I think that this is, and what are the blankets like? There's a lot of things that you can ask. So you got to get the mood right. Is the mood right at bedtime? So you have to set yourself up for success. And so it's appropriate bed, appropriate blankets. And if you don't have what you need, then you need your providers often to write letters of medical necessity, which is, one of the issues here is that your insurance company isn't going to do it unless you jump through all of the hoops to get the paperwork in line. A sleep study is needed if there's snoring or excessive daytime sleepiness. Sometimes your child might need something like their tonsils out, but they may also need something else to help them to sleep, like oxygen or positive airway pressure, and sometimes that's really hard to tolerate, but there are ways of desensitizing you to get used to these sorts of equipment. So there are medications for initiation. Primarily this is melatonin, but I think that with most folks here, it's not about getting to sleep, it's about staying to sleep. And so there are medications for both maintenance and initiation, and my favorites are clonidine, gabapentin, and trazodone. All of them work? No, they don't. So my approach is you try one, then if it doesn't work, have a plan for coming off of it and going to the next one, and so on. And you keep trying stuff till you try to find something that works. And then there are additional medications that were listed from the natural history study that people have used, and this is chloral hydrate, Benadryl or diphenhydramine, sertraline, and zolpidem. Chloral hydrate is of course, impossible to get these days. And then there are additional medicines that I found that our people were using at Children's, and these use risperidone, but also artisanal CBD and THC preparations, and which opens the can of worms that Eric already opened. And the issue is that all of these have a variable response. And there's other things that I think that are worth trying. And I'm always open to trying something new because I know how your lives are affected with not going to sleep. And there are these now new things called melatonin antagonists. Oh, sorry. I think we are going to put the slides up so you don't have to take pictures. So the next thing is approach to communication. So I ask questions, well, how often is speech therapy? Is it useful? And one of the good questions was, well, if I do all of this, is it doing anything? And we don't necessarily know the answer to that, but I think it's a good question. But we all know that if you don't push it, the reason why you should push it is because you're going to notice that your child's frustrated because they have something to tell you. And your problem is you don't speak French, and that's the problem. If you could just learn to speak French, then you could understand what your child is saying. So one of the things that I ask families to try to understand in their child is tell me about their yes mannerism. Tell me about their no mannerism, and who can recognize each of these. And if you can recognize it, then you can teach their circle of teachers and their circle of friends and family to recognize those mannerisms as well. It's a good place to start, is to try to figure out their yes and no's. And are they using assistive or augmentative communication? And is your speech-language pathologist comfortable with it? Because those are two very different things, as you know. And is this used at home and school? And a lot of times, oh yeah, she's using it at school, but it hasn't come home yet. And it's like, okay, great. Well, yeah, we have it at home, but I don't want to turn it on because I know what he wants already anyway. So as you can tell, these are my pain points, if you will, that these things need to be used consistently in order to be effective. Has cortical visual impairment been taken into consideration for whatever the device is being used? And I know Christine Roman-Lansky is going to talk more about this. But also the other point is was the teacher of the visually impaired involved in setting this up? So my approaches and what we see in our clinic is people are using iPads, they're using Tobys, they're using head switches, Big Mac switches, and then also homemade versions that you can make with a 3D printer. I can tell you more about that later, but basically, you know those really sweet switches that cost $80? You can make them for under $3 with a 3D printer. But what are the uses? Yes, no's, they're making requests, they're requesting the sort of music that they want to listen to, which is not what you like. They're activating toys, games, they're getting attention. And what I think is needs to be more of is people to use yes-no cards and to work more on gesture recognition. I think there's a lot more that we can push and get done there. And so how do we do that? And the challenges are that the devices are bulky, they're unreliable, and they're cost. How many times have I said, well, yeah, we have a Toby, but it's in the shop? It's just 50% of the time, it seems. So these are my approaches. Now, I'm not going to read all of this. You can just pull this slide off. But basically, I blow this into my note that you take home with you. But it's the sort of thing that you can all use. But the key thing here is that there is guidance. It's online. It's something that now International Rett Syndrome Foundation has set up for your speech-language pathologist to do. And if they do it, they get free continuing education credits, which is a bonus for your poor speech-language pathologist who can't afford this. They can get it for free. But there's also things, if you can look at these videos too. There's no barrier to looking at them. But there's also some other resources about learning yes, no. And so these are, I think, are very useful for families. I also have this blurby thing that I put into my note about therapies. And it's got a lot of legalese in there, and I'm trying to remind insurance companies and schools that they have an obligation to your children with regards to what they provide in school. School is not babysitting, school is education. And then I also have another blurby that I like to put in about cortical visual impairment with also some useful things. And again, there's a lot of issues surrounding what the school has to do by federal law in order to take care of your kids. So what to do? The bottom line is that there are no proven approaches to sleep and communication. This is an unmet need. It's only through trying to do things systematically will we come up with the answers to these questions. But I think it's important that you working with your clinicians, you work on things and try things. And when it doesn't work, you say, okay, what's next? But give each thing a good try. Especially with the communication, I think it's really important to be consistent. Especially with sleep, with setting the mood at home, it's important to be consistent. Medications for sleep, start low, go slow, move to the next. And like I said, be consistent with communication. But the bottom line is, as I put there, you're always going to be the best advocate. Keep in touch with your clinicians, and I think that's the approach I'd suggest. So thanks to everybody, especially our FOXG1 families and my team, and those people that I had the privilege to work with the natural history study. So thanks very much. And then I would take questions, but we're going to do that later. And do you want to talk about the standard of care slides now, or maybe wait till later?
Let's bring it up in the questions.
Okay, perfect.
Yeah. Thank you so much, Tim.